I will now officially open today's Board of Health board meeting. Let's go start with the agenda. And today I'll remember numbers. So I go 1, 2, 3, 4, 5, 6, 7, 8, 9 to 13 without screwing it all up. So call to order, and I'll talk with the doctor. Please begin with you.
Bob Lutz, appointed citizen.
Kevin Freeman, Small Cities Representative, Mayor, City of Millwood.
Chuck Hafner, representing the City of Spokane Valley, and the Chair of Spokane Board of Health.
Susan Norwood, appointed member.
Michelle Fossum, Legal Counsel.
Ann Pittsnoggle, Recording Secretary.
John Snyder, City of Spokane.
And Mike Fagan, City of Spokane.
Keith Baldwin, appointed member.
Joel McCullough, Spokane Regional Health District.
Okay. Start Michelle and Torney.
Torney Smith.
Okay. And let's start over here, please, at the very end. Introduce yourself. Okay. Yes, ma'am.
Joan Mutree.
Okay, thank you.
Rosemarie Walden,
Okay.
citizen allergic to fluoride.
Okay, Linda.
Linda Graham, health policy and sanitation senator. Andy Wilson, director of disease prevention and response.
Elaine Conlon, director of community and family services.
David Swank, director of environmental.
Okay, and Amber, please. Just had the introductions going.
Amber Waldrop, City of Spokane.
Okay, thank you, Amber. We now will have citizen input. Remember, you have 3 minutes to speak. And are you going to speak today? Okay. Yeah. Okay, Rosemarie, please. And remember, Rosemarie, as I have spoken to you, you have 3 minutes or less, my dear.
Rosemarie Walden Larson, Green Acres, Spokane Valley City. I've been coming to these meetings for 18 years. And I'm going to say again what I've said 18 years ago. That which sounds too good to be true usually is. Beware the truth decay in fluoridation promotion. Fluoride is not a mineral. Fluoride is a compound that is not life essential. You will not die, nor will you become sick from a lack of fluoride. However, the opposite is true. What if lowering the amount of drinking water fluoride is because, in addition to toothpaste and mouthwash, fluorides are the common denominator in drugs-only consensus medicine, which includes vaccines, GMOs, and their frankenfoods, which aren't tolerated by everyone when bioaccumulative fluorides are now available everywhere in everything? What if behind the scenes a Kaiser-friendly corporate special interest was the bias in the late 80s era Spokane City Council, the one that bought the Spokane incinerator and its downwind fluorine-polluting, outdated technology before the contract was signed, by paying a special interest twice the amount of a local contractor's lower bid, which was rejected only because that local contractor was willing to unconditionally guarantee his work? What if there's no reason to fluoridate this region's water now because it's possible another environmental impact study would again show that since 1991, the Spokane Waste Incinerator has been and still is fluoridating everything, everyone, for 200 miles downwind with its hydrogen fluoride, gas, and microscopic fluoride particulate fallout? What if Grand Rapids, Michigan, the 1945 to 1955 fluoridation test was fraudulent, its non-fluoridated control city getting fluoridated 4 years before the 10-year test was to end? But the New York State Health Department 10-year test, which fluoride promoters seldom mention now, was completed, showing the streaking or spotting of teeth was the first and safest of low-dose but short-term fluoride poisoning symptoms. The worst are listed for you, and they begin with premature aging and include childhood schizophrenia, which they now relabel as autism. What if the June 1950 announcement in the American Dental Association Union's newsletter was not based on science, but the energetic politicking of one, now this I am not kidding, his name was Dr. Frank Bull, a member of the Wisconsin State Health Board who literally nagged, shamed, and coerced an endorsement of fluoridation from Assistant Surgeon General Dr. Bruce Forsyth at a meeting of all heads of each state's health board in Washington, D.C., May 1950. Thank you.
Thank you. Okay, next we have, and see if I have this name correct, is Joanne Mutree? Joan Mutree, okay, thank you. 3 minutes, please.
All right. Hello, my name is Joan Mutree. Back in the early 1980s, I started a 500-member citizen group in Spokane called the Hanford Education Action League, HEAL. Some of you may remember it. We were responsible for lifting the lid of secrecy off of the Hanford Nuclear Reservation insofar as its gross chemical and radioactive contamination being constantly emitted and even purposely dumped on the Northwest population. Among those toxic elements is one very nasty byproduct of the nuclear weapons program, and that is fluoride. I recently heard there are some officials in Spokane who are contemplating adding this poison into Spokane's clean water supply, a water supply which is presently a source of pride for the region, as well as envied outside of the region by those in fluoridated areas who are forced to buy bottled water in order to protect their health. Some of us wonder if bottled water companies, along with certain dentists, are somehow seeking to enrich themselves by supporting such an action. The previous speaker mentioned some alarming facts about fluoride and how it was put into water supplies many years ago without public attention. But this is now the year 2015, and I want to point out that there is now an internet available wherein there are literally thousands of scientific medical studies exposing fluoride dangers, making it much more difficult to defraud an aware citizenry. I want to make something very clear. My experience in encouraging 500 citizens to join a group concerned for their health gives me great confidence that any attempt to fluoridate Spokane's beloved water supply would be met with serious regional resistance. I am here to warn those of you who might be considering such a travesty to desist. Stop. And if there are any among you who believe you can circumvent citizen involvement by attempting a policy approach, please think again. There have been wars fought over clean water. Do you really want to be that kind of a catalyst? Do you really want to bear the responsibility for putting a known toxin in quantities that cannot be individually standardized into the bodies of those who live and travel in the Spokane area, even tiny infants and the infirm? For just one example, dialysis kidney machines cannot use fluoridated water because it is known to be potentially dangerous to patients. A National Kidney Foundation report indicates that some people receiving dialysis treatments died or were poisoned from fluoride after it leached through machine filters. Please hear this. Fluoridation of public water is an experimental, invasive medical procedure that befits a gulag, not Spokane. Thank you.
Thank you very much. Are there anybody else? Yes, ma'am.
My name is Cara One Ticket, and I'm going to talk off the top of my head today. I'm going to remind you that Baltimore was where we went to find out about burning garbage. It was the first and the only known plan at that time. So those people are probably polluted from the garbage that's burned in Baltimore. Now, this information is respectfully submitted in good faith. We are not paying attention to all the things that are going on because we're all busy with our everyday lives. The Good Bilderberg group is putting out the information through their different people they've connected with. I hope you've had a chance to look at their book. It was written by a man in Spain whose family who lost his friend who was investigating them. These people are the ones that are behind what decisions are made all over the United States and all over the world. The other book that I mentioned last time I was here was The Symptoms of Autism. It's a very informative book. I hope that you'll have a chance to get a hold of it and learn what autism does to a person and how they can react to you as a person improperly because you don't understand why they're not doing what they're supposed to do according to the rules of social etiquette. I got a ticket for $30 parking on a line in the parking lot last time I was here, and I had to have Daniel go and pay it for me. I gave him the money. So I'm not very happy about parking in that parking lot or any parking lot for that matter. Anyway, I hope that some of the things that I've said will start you looking for more information and not just rely on what you get handed to you at these different meetings. There's a lot of things going on in this world that people are ignoring, and I hope that you will have the kindness to listen to Rose tell you about what she has said. And I look at a lot of different things. I got a whole front seat of my car full of books that I've been reading. So I can't even, and I sat in it and fell asleep last night. So I'm not really my best form today. And respectfully submitted in good faith. Thank you very much.
Thank you very much. Please note that Mr. Ed Pace has shown up. Thank you. There's a couple things under the chair report I'd like to make. First of all, sometimes we don't understand and realize the enormous task that staff in this health district have and the obligations and responsibilities that they set forth to make sure our county is safe. And I just want to note, I'm sure I'm expressing everyone's thoughts, thanking them because they have to be involved so many multiple things in order to get the job done. And I just want to say personally, as the chair and probably representing many of you and all of you, just thank you to all of them. The other thing, if you'll recall, when we first started out this year, a couple areas that we wanted to really emphasize, and we set up some committees in order to do that. We've always had a budget and finance committee that I think has met a couple times now, and they'll be coming back with you at our next board meeting to give you a general idea where we are with the budget. And they've been spending a lot of time doing that. And again, I'm simply saying, appreciation-wise, thank them very much. We also have the Education and Communication Committee that Bob has so well chaired for many years, but I think he's done an exemplary job with Susan and Kevin this year and all the things that they're accomplished. And so I just want to say again to thank you for that. We had a governance committee that meets quarterly now. But last year we spent a lot of time in determining, where and what our behavior should be as a board. And so we, again, will have a quarterly report relating to that, which I'm sure that we'll find an update on how we are doing as a board. We then also have a TFE permit ad hoc committee set forth by Shelley O'Quinn. And, of course, that's been really one of the most interesting because they're meeting now geographically with other health districts in the state to determine what fees should be reasonable for, let's say a one event or a two event or a three event occasion, and what should they be charged in order to do that and yet have safety factors involved in it. And so the question is, do we lower the fees so a lot of people can be involved, but at the same time, if we lower the fees, do we not have the proper inspection to make sure it's a healthy vendor situation? So that's very, very interesting. We met yesterday. We plan on meeting, I think, after June the 26th, again at their last meeting, I think, is that correct, Kevin? And we're meeting again, like I say, with people from the west side, health districts on the west side. They're having the same concerns we are. We want people to be able to be a vendor and not where it costs them a lot of money in order to do that. But we also want to make sure that it's done in a safety thing.
July 7th.
Oh, July. I guess I'm sorry. Thank you. In July. Thank you very much.
Thank you, Tony.
Then we also have the executive committee, which is made up of the chair and the vice chair, and we can't exceed 5 of us simply because we'd have a quorum. But I'm requesting that any of the board members, if you have something you would like to be put as an agenda item, please bring forth to myself or Kevin or even Torney, Dr. Joel, and Dr. Lutz, because we'd certainly bring it forth on the agenda. But here again, you need to bring those to us and allow you to do that. But I just simply want to say thanks to all those committees because they are spending many, many hours of getting the job done. And when you think about any one of us sitting here at on this dais, anytime there's a schedule change, we almost go into hysterics because we have to change so many other schedules that we have in order to accommodate what we want to do. So I appreciate everything that you do at that time. If you'll notice back on your agenda, you do have a Board of Health governance responsibilities. And here again, you need to occasionally look at those and see exactly what we're supposed to be doing or how we're doing. Other than that, that's all I have to say at this time. So I will turn it over to Dr. Joel for a health officer report, please.
This afternoon, I'll be updating you on where we stand with the measles, and finally give the information about the county health rankings that we've been talking about for a couple months. And I will be announcing an important SRHD retirement. And then I'll hand it over to Mike later on to talk about the auditor's exit conference that we had earlier today. So in terms of the measles, don't have a lot of additional information from the last meeting. So we did end up with 2 laboratory confirmed cases in adult Spokane County residents. And I think one of the main issues for that is that the staff put in a lot of work to that. So there's a lot of work that goes on behind the scenes to contain these infectious diseases. So staff contacted well over 300 people that were exposed or potentially exposed. They determined their immunization status, made quarantine recommendations. They put on clinics for those who were exposed to come in to have their laboratories drawn to determine their immunity to measles. So there was a tremendous amount of work done by staff. So I think they did a really great job, and I think much of that work was successful in limiting the cases to only two cases. And also some of our community partners stepped up and assisted, especially organizations like PAML that assisted us in these clinics. So it was definitely a successful community effort. Changing topics, been talking about the county health rankings for a while, and I've reported previously on this topic. Again, a little background. The county health rankings is a collaborative effort between the Robert Wood Johnson Foundation and the University of Wisconsin Population Health Institute. And what they hope to do is to rank every county in the U.S. And so with this ranking, you will have within-state ranking of the health of the population. So this diagram shows basically how this is done. So each county will receive 2 measures. You have the health outcomes, which consist of the length of life and different quality of life measures. And each county will have another ranking, which is called the health factors. And it's made of the traditional health factors that we normally think of, the health behaviors and clinical care. but it also have some additional factors as well that we normally don't think of as contributing to health, such as social and economic factors and the physical environment. And again, this allows for within-state comparisons, so you'll have rankings. Each county will have a within-state ranking. So in terms of the health outcomes, this is a map of Washington State, and the lighter areas shows that would categorize as the healthier counties, and the darker ones would be the least healthy counties, as according to this ranking system. And for health outcomes, you see Spokane here is ranked, it's in the middle, and so the rank here is 22. And this ranking has been pretty consistent in previous rankings in terms of when we look at health outcomes. And for this year, Whitman County to the south was rated the healthiest county as it relates to health outcomes. And you usually see this, Snohomish, King, and Island and San Juans are usually up there as well. For health factors, which is the more complicated measure, Spokane again is in the middle here, and the ranking here is the number 15. And so we generally tend to do better in the health factors area, and we tend to do well in the clinical factors areas, so the clinical quality and accessibility. So those are the areas that Spokane generally does well in. And for the higher ranking ones are again Whitman and Snohomish, King, and the ones that we talked about previously. And so these measures came out about 5 years ago, and some communities are using these rankings to help mobilize the communities to achieve specific improvements in their health. But that really has not been necessarily the case here in Washington State. So perhaps that may change later. So finally, I'd like to announce the retirement of the important member of the SRHD executive team. And she's sitting back there, Elaine Connolly. She's the Division Director for Community and Family Services. And so certainly Elaine has had a really strong and powerful career here in public health, has been a towering figure here in the state of Washington, known for innovative thinking and not accepting the status quo, and so she will definitely be missed by our agency. Elaine gave us a couple months to adjust to her leaving, so she's going to be leaving in the end of July, and so we'll try to squeeze as much information out of her before she leaves. So again, thank you, Elaine, for serving public health. And that's all I have. Thank you.
Are you going to have Mike?
He's going to do it during his presentation.
Oh,
he's going to start with that.
Okay. Yes, that's what I was going to add. Any questions? Dr. Joel, please.
You bet. Thank you, Mr. Chair. Doctor, have we received the results back to identify the type of strain of measles and where it originated?
For our specific case?
That's correct.
No, we have not.
Okay.
Well, we did have... the strain was from an Asian strain. So I forget the type of the number, but it was an Asian strain that has been identified in Asia. But in terms of where the initial case that exposed the case that we know about, we do not have information on that individual or who was case zero. But in terms of the strain, we know that it was a strain that was more common in Asia.
Okay. Kind of shifting gears onto a different subject. About 3 weeks ago, saw some reports of pneumonic plague being identified in fleas and prairie dogs down in Arizona. About a week later, another report came out with regard to pneumonic, now called bubonic plague, involving at least 3 to 4 people in Colorado and a dog. Is there any further information, anything that we as a board need to be concerned about on that?
Well, certainly we have had surveillance has shown that the plague has been found here in Washington State among some rodent populations, such as prairie dogs. So we haven't had any recent cases here in Washington State, and certainly you can get either pneumonic or bubonic plague associated with exposure to fleas that have been exposed to the rodents. Certainly. So to answer your question, yes, it's something that we should be concerned about. There hasn't really been any recent surveillance findings here in Washington State, but we have known that it does exist.
All right, and then the final question, I'm sure you caught the headlines with regard to the live anthrax shipping mistake.
Yes.
Don't have any further information on that, but I understand that there were multiple test facilities or labs that had this material shipped to them. So would that be something that we need to be concerned about or keeping a finger on the pulse of?
Well, certainly, have you seen in the news that the Department of Defense did ship what they thought was killed anthrax spores to several state labs, but apparently that process did not occur in terms of the killing of the process. So I think the main concern from that incident would be those potentially exposed in those labs. So my understanding that some of those people who were potentially exposed or on antibiotics, should their exposure might have resulted in disease. So as a precaution, some of them are on antibiotics. But in terms of widespread public exposure, there really should not be any exposure to the general public from this error from the Department of Defense. And my understanding also is that the Centers for Disease Control is also in the process of investigating of what went wrong, so that doesn't occur again.
Thank you.
Okay. Any other questions of Dr. Joel?
Yeah, Dr. Joel,
Yes.
my household recently received a Health District Quality of Life survey.
Yes.
And I was just wondering how long that survey is going on and when the board might see the results.
So I believe you received the second mailing. So there'll be 3 mailings, and the time frame for completion of the results. Linda, do you have the information about completion of results?
In the next month, we'll have some preliminary and then probably final by August.
Any other questions?
Yeah, so
Dr.
the
Joel?
quality, just for orientation, the quality of life survey, it was a effort kind of spearheaded by the data center here in Health District, but working with several community partners, county government, city government, healthcare facilities, to determine what measures they would need to help them in decision making about the quality of life and services that are available in the community. So the quality of life survey is a collaborative effort by us and our community partners to find out more information about what's important in our community.
Dr. Joel, you mentioned that was potentially the second mailing.
Yeah, I believe it was a second, because there's several mailings that went out, and because the mailings go out because if people don't respond to the first one, they get several other mailings that.
I was just curious if you had an indication or some sort of update or some sort of status as what the response is.
It's actually really good. We've got over 3,000 surveys back, so it's very generalizable, and we'll be able to cut and dice it in several different ways.
Okay. Any other questions for Dr. Joel? Okay, thank you very much.
Thank you.
Okay, let's go now to the legislative report, please. Linda Graham.
Good afternoon. My voice is less than ideal today, but it should at least guarantee a very quick report. As you probably are aware, today is the 30th and final day of the special session at the legislature. For the most part, they've been focusing on budget, and I think the general summation is the work has been less than thoroughly productive. And it looks like we will be heading into a second session. The hope is that this will wrap up fairly quickly, but state agencies are making efforts already to, just in case we do hit the end of the year without a budget and we have a shutdown. So efforts are already underway there. In addition to the budget, there has been some movement on some policy bills, but that's even been fairly limited, and certainly nothing making it all the way through, mostly committee meetings. They've also had some different work sessions, but main focus has been on the budget. At this point, we, as public health throughout the state, are really down to three main priorities. WSALFO, our statewide organization, and then LHJs from across the state have really been active in trying to get some movement on these issues with the legislature. To the extent that you are able to also engage in working with legislators on these, we'd certainly appreciate the added help. There's a lot more detail on each of these in your packet. If you do want to reach out to legislators and feel like you need more information, please give me a call. I can certainly provide that to you, hopefully by email, not by phone right now. But the three big issues are e-cigarettes, like we've talked about all session. Things have been broken into two bills now. One is the regulatory structure around e-cigarettes, and the other piece is the taxation, with about 40% of that hoping to get for public health prevention and outreach efforts, mainly. For marijuana, I'm really urging the legislature to follow what is spelled out in the initiative 502, that some of the revenue would go to local public health jurisdictions for prevention efforts. Right now, this funding is not secured in the budget at all. And then coordinated prevention grants, this has been significantly cut, proposed in both the state Senate and the House budget, and it's cut in about half, unfortunately. And this money goes through Department of Ecology. Some of it also comes to local health jurisdictions to help with solid waste management and inspections and dealing with complaints and compliance and education. So we're really working with the legislature to try and get that funding back up. I'm going to stop there unless you have any questions.
Okay. Any questions to Linda?
Okay, good. Thank you.
Okay. Thank you very much. Okay, item number 7, the consent agenda. There are two items: the meeting minutes of April 30th, 2015, and vouchers April 1 through 30th, 2015. Do I hear a motion to accept those, please?
Move to approve.
Hear a second?
Second.
Okay, any discussion? Hearing none, all in favor signify by aye.
Aye.
Those against? Thank you very much. Okay, at this time, we will be moving into an executive session. And we will be moving up to room, 311? Okay, Michelle, would you give the process for us, please?
Sure. We are meeting an executive session to discuss health officer evaluation pursuant to RCW 4230-110-1G. And Mr. Chair, how long do you think we need? 20 minutes maybe?
30.
30
minutes?
There will be some discussion.
Okay, for 30 minutes.
Okay. And we'll go down this hallway for the elevator. Is that correct? Okay, thank you.
At this time, I'd like to tender forth a motion that we offer to Dr. Joel McCullough a 3% salary increase effective June 1 of 2015.
Do I hear a second?
Second.
Okay. Any discussion, please? Hearing none, all in favor?
Aye.
All those against? That passes. Let's go to item number 9B, please. Mike?
Oh, no. Uh-oh. Hi, thank you. One thing I want to talk about today is we had our audit for our 2014 audit. The auditors had the exit interview today, or exit meeting today, so they came there. I do want to thank Councilmember Snyder and Councilmember Hafner and Mr. Baldwin for showing up and attending that and adding some very good dialogue back and forth with the auditors. We had a nice discussion. I am very happy to announce that as an agency, we had no findings. We had no management letter, and there was a very one minor exit item that just had to do with the positioning of a number on the financials. So it was very nice, and we were very much praised by them for that and for our financial condition at the moment, because they're starting to look at that too. They're going out to all entities and seeing where you're at financially. So that was very nice of them to let us know that. What I'm here for today is to present Resolution 15-03, which is a budget amendment to our 2015 budget. And what I want to, and I know it was sent to you, and I think it's either on the back of the resolution that you currently have. And what I am mostly going to talk about right now is going more in detail on the revenue side of things. As we go down the revenue items, you can see we have no federal direct dollars, but you can see in the federal indirect there's a $764,000 increase of money that we received, and those were very good. People have been working hard putting in grant proposals and receiving some of these grant proposals, and I just want to tell you a little bit about some of them. We have a 1422 grant that is the prevention of diabetes, obesity, and high blood pressure. There is a Department of Transportation CMAQ grant that has to do with the Walk, Bike, Bus program. There is a public health block grant that's going towards the Healthy Eating, Active Living program. We also got some foundation money it's called Foundation for Healthy Generation, and some FINI money, which I don't even remember what that stood for. But those monies are to enhance the SNAP Ed program, which Donna's going to talk about here in about 3 minutes. So, and then we do have our LCDF grants that we get from the state that we're assigning out to some programs. So those are all in some of those numbers up above there. Well, I apologize. The LCDF is actually in a different spot, but those are all some new grants that we received. We also did have some additional funding in our ASPR Regional that's in our Public Health Emergency Program. There was some additional funding that came in there. There was some additional WIC funding that came in because of the caseload of clients that we have. And then the SNAP Ed that she's talking about had some increased dollars that came in. So these were all very good. In addition to that, there's also some money that always rolls over. Money that we had for grant money from October through September that we had budgeted last fall, but they didn't use it all. They can roll that into this year. So all those are part of those increases on some of those federal indirect dollars. Moving down a little farther, I'm going down to the public health fees. The increase in the public health fees is there was the authorization by the county that we could increase our caseload in the opioid treatment program. So we're going up to 700. This doesn't reflect the increase all the way up to the 700 because, of course, I think we're currently at about 619, and we are trying to work our way up there. So we used an average of about 645 or something for this year to come up with the fees that we'll collect so we didn't overstate what we were pulling in. And so those are in that line. And then as you move down to our 308 reserve funds right down here, we are asking to use $600,000 more than our original budget in the reserve funds. And what these are, we had some things projected last fall, such as like the elevators that we were going to do in the 2014 budget, was approved in the 2014 budget. We did not do them, so we took those money, put them out in reserve. I'm now asking those to pull those back out because we are ready to do the elevator work in that category. So the other items that are the revenues here are really just shifting of dollars. The state went through a big re-looking at how you what number we put them under. In fact, in the 2014 report to the board, our financials, we had to report them in the new numbers. So we had to take all our 2014 numbers that we had budgeted in different places, but actually put them into actuals into correct locations. So if you look up here where this is there wasn't a great big drop in this TB, Medicaid, Medicare. What used to be in that line item also included the school district money we get. It used to be called intergovernmental. Intergovernmental went away. It used to be a 338.000. That went away. Those came out. New numbers were given to TB and Medicare and Medicaid. The school district money had to go somewhere. They said the school district money moved up to state of Washington. So school district money moves up to state of Washington, becomes state of Washington dollars. However, in state of Washington, the LCDF and the 5930 money had to be pulled out and moved down here to the public health appropriations line. So all we're doing is cleaning up where these numbers are going in the budget as far as those ones go. So really, those first numbers I talked about, the increased grants we got, the increased fees, and the increased reserves are the addition that we're asking for as far as expenditure authority. So when you go down to the expenditure authority, those numbers, those grants are the things that are creating that. I did go over with both the Budget Committee and the Exec Committee in more detail, line item by line item, on some items. I wasn't going to do that today for the sake of time, unless people had specific questions. But I was going to mention that we do have on the expenditure side, if you looked at it over there. There is the 8.11 increase in personnel. This puts us back up to about where we were 2 years ago. And so it is increasing us up to there. And I know the question that's often asked is, how are those being paid? And yes, most of those, majority of that is all being paid by grant dollars. So if those grants went away, there would be reductions in positions to go away also. So these are new grants that Health Promotion has done a great job of pulling in, and our DPR has been doing very good about. All divisions are working on hard on getting new monies in. So I hope that we look forward to passing 15-03.
Any questions of Mike? Do I hear a motion to accept resolution number 15-03 authorizing a 2015 budget amendment?
I would move to accept it.
Okay, do I second? Okay, any discussion? All those in favor?
Aye.
Those against? Thank you very much, Mike.
All right, thank you.
Donna, finally. Community health workers. I think this is going to be most interesting. And you have a helper.
I do. I am not alone.
Okay.
And how are you feeling about time, since I know you're a little crunched?
Well, how much time do you need?
We'll take 15, 20 if we've got it. Otherwise, we'll make it work.
What did you
for
plan on?
15.
Okay, let's just do the 15 then.
Okay. Bear with me one sec here. Well, thank you so much for the opportunity for us to share this work with you. My name is Donna Oliver, and I'm the program manager for a couple programs in health promotion. One is our breast, cervical, colon health program, which is a cancer screening program. Another one is our SNAP-Ed program, SNAP standing for Supplemental Nutrition Assistance Program, the name for food stamps. It's an educational arm for educating the SNAP population about making healthy choices around healthy eating and active living. And embedded in both of those programs, we're doing a lot of work around community health workers. So I don't know if this is a term that you are familiar with at all. It's something that is being talked about a lot right now, especially since the implementation of the Affordable Care Act. It's actually written all over the Affordable Care Act. And community health workers in many ways have been around for years. And they've perhaps been called by a lot of different names: promotoras, peer counselors, patient navigators. There's a lot of different titles and roles that they may have been called. And I think we're really recognizing that as we get into an era where more and more folks, for instance, have access to medical insurance and a lot of other reasons, that these folks can be real instrumental in helping our population to become healthier. The American Public Health Association actually has a definition for community health workers, and in essence, the words are on this graphic for you. This is a fun little graphic where you put in the definition, and it scales the words according to how often they're really noted in there. And if you notice, health and community really shows up. But basically, they are frontline workers who either are part of or have a unique understanding of the community in which they serve. And that's really essential as we talk about what they are, and in my mind, what they're not. Because there's a lot of conversation going on around calling people community health workers. A lot of studies have shown in several different arenas that they can be real effective in helping control, for instance, different medical conditions like diabetes, high blood pressure. They have been shown to be cost effective, and as far as a return on investment, in some cases like 3 to 1. And they really help improve the patient experience. I don't know if anybody can identify with the fact that, have you ever been told by your medical provider or even a commercial or something that you should do something? You're over age 50, you should have a colonoscopy, whatever it might be. And you take that as, yeah. But then as soon as maybe your sister, your neighbor, someone tells you their story about, oh my goodness, did I tell you about how I went in and had this done? Luckily they found some polyps and it won't turn into cancer and it really wasn't so bad, et cetera, et cetera. Hearing something from somebody that you trust, you have a relationship with, perhaps knows something about you or your community, often resonates just a little more with us than if we just get that educational message. So really, in essence, that's a little bit of what we're talking about here. As we talk about the different types of roles, I want to recognize that there's a lot going on right now around the term community health worker. So, for instance, there may be roles for a community health worker within some of the medical or organizational settings. Someone who perhaps is a lay person, who understands the community, who is able to take time outside of the doctors and the medical assistants to help patients access resources, make sure they're following through with something. That's been shown to be effective in some things. It also can be someone from an organization who really can help, for instance, reach certain populations. We have an example where we actually had some great curriculum and messaging around breast cancer screening for the Russian population, and went in with all of our ducks in a row and found that we didn't have a whole lot of participation. We took it to a community center, we had the colleges involved, etc. And then we stepped back and we utilized someone from that community who knew what worked, who knew where we should go, how to connect to people, and it was far more successful. We took it into the churches. We had people coming just because they knew her, they trusted her. That's an example, of course, where if you actually have someone that is from the community, understands them, and is trusted by folks, you can get much further with outreach. But in my mind, that's also really our somewhat traditional approach to the work that a lot of our systems do. We're either having people come into us, to a medical office or an organization, or we have employees that go out into the community to teach, to do, and that's great. But what we're really venturing into right now is another piece of that we feel is super important, and really a big role for us is in public health. And that is engaging people who are from the community and within their communities. And that's something we're actually doing in our SNAP-Ed program. And so that's why I've really broken it out on this slide, that there is a difference between the people who are working for and from organizations and perhaps what we're doing, where we're actually recruiting, empowering, training, and utilizing people who are part of the populations that we're all trying to serve. Make sure I've got my notes all in order here. So when we talk about what they're not, and I just want to mention this because I feel like I've seen this a little bit, is they're not just renaming the work that our systems are already doing. Really, we're talking about extending the reach past where we are able to already go with the systems we have, and therefore really enhancing that. So what are we doing here? Some of the work that we're doing here, one is we've been partnering with the State Department of Health for the last 3 years and helping to implement a community health worker training, actually for our 9-county region. And this training is very accessible. It's free. It's part web-based, part in-person. There is a brochure that you have that talks about that. It really addresses kind of those essential components that most people would need, things like communication, organizational skills, understanding your roles and boundaries, etc. And then they have opportunities to take a lot more health-specific, topic-specific modules online. And this is something we do quarterly. This has involved, and you have another handout that really shows the several different organizations who've already sent people through this community health worker training, along with some individuals and volunteers. And so at this point, we really have quite a cohort of folks that we are now working. That's actually the third bullet there, but I'll go into that because it's relevant, as we're working on now ways that they can all connect to each other, because that's one of the things that people have been real hungry for, whether they're from a medical clinic or a community organization or a volunteer in a community. They love the fact that they would really like to have more information on resources in their community and how to connect people to each other. But the other piece that Marion's going to share with you in some more detail about in a few minutes is the fact that we are also working on that place-based community health worker model. And what we're doing there is within our SNAP-Ed program, we are actually working in several low-income housing locations in Spokane. And we have actually recruited and trained and are working with people to be those community health workers in their community, to hear from their communities, and have them help share health information, help teach some of the curriculum that we have. And this approach is very innovative and new. USDA funds the SNAP-Ed program. They're real excited about what we're doing because traditionally what they've had, as Marion has so well coined it, is more of a stand and deliver model where they have great educators around the United States that may be from different organizations go out into the place and teach different classes on eating healthy within a limited budget, stretching your food dollar, etc., and then leaving. And we're really offering something different, where we're working alongside these folks, providing them the education and a simple curriculum and having them help share that. And it really is then springboarding a lot of other activities within their communities that come from that and help support that on a daily basis, where they live, where they play, etc. The other thing that we're involved in is we're really working with some of our community partners, both statewide and locally here. Better Health Together is doing a lot of work in that organizational and clinical area around community health workers. And we've all come to the table recognizing that we have a couple different components here and that the community-based folks are real vital to not only the work that's being done and really meeting people where they're at. You know, we can throw all the education we want at folks, but if they're living in an environment where it's tough to make a healthy choice, I mean, that's really where the rubber meets the road. And so we're really having some conversation around what this model looks like for our community, how we can link those folks together to link that community and that medical system, and we're hoping to really have some great things that come out of that. Including the voice of the people who are community health workers. In addition, Foundation for Healthy Generations, which Mike mentioned, is one of our funding pots. They're a nonprofit out of Seattle who is doing some similar work with this kind of model. And we have been real fortunate to have some additional funding from them that allows us to enhance the work we're doing and provide some things that we otherwise cannot pay for with USDA funds. For instance, bringing together the community, hearing from them in each of these neighborhoods what they're interested in, what's important to them, providing food that helps with meetings like that. That's an example. And they have really been partnering with us and sharing what's going on in their area and in our area to the state legislature and to healthcare authority. And so we've been a part of some of those conversations that are happening there. So at this point, what I'd like to do is I would like to introduce Marion. And I am so fortunate to have an employee like her because I knew that bringing in someone to work directly on implementing this model and working with the folks in these neighborhoods, that we needed someone to really have a heart for that. And you'll even notice that, you know, she's dressed in jeans because she's going to be out at one of those communities today, and that's strategically important for the work that she does. So at this point, I want her to share for a few minutes what she's been doing.
Okay, here we go. Good afternoon. Thank you, Donna, for making the disclaimer of why I am not dressed very fancy to come present to you guys. You're a very important part of our organization, and I really greatly appreciate the opportunity to have a conversation with you about this topic. So, to use a term that actually Donna, I think, accidentally stumbled on saying, it so eloquently represents what we're up to with this project, it's the give-get model. So every time we have worked with these folks, including at the community level, we have really intentionally gone in to give them something, some information, some education, some resources, but not shying away from getting stuff from them because they're exactly the voice we want to hear. So my role in the community health advocate, we call them advocates, but we'll get there, is around recruiting and training these individuals. So again, like Donna mentioned, the community that we reference here is like the apartment house or the apartment complex. So while a lot of people think community is a very broad term, in this context, we're really using a narrow definition to some degree. And really the success has come from allowing the community to have a voice, allowing us to come in and reach somewhat of an unreachable audience. These are folks that would say, email what? Or They don't have access to a computer. They don't have any clue about social media. They don't have any of those types of things. So we intentionally have had a strategy to go to them and have conversations with them in a very informal way, obviously dressed kind of like this, and just engaging them. And this is a population that isn't necessarily used to being listened to, so they have really embraced the give-get model. Someone's listening, and we can drive them to action based on the fact that we're gaining credibility with them and trust with them. So going to them, finding out who the natural helpers were, that's what we intentionally started to do. But what has actually come to pass is it's not always the natural helpers. Sometimes it's the quiet leaders that have come forth and have really set some great changes on their properties. And the training also includes kind of that adaptation piece where we had them come here, which was very difficult for this audience. They are very much based in their location. Most of them do not have cars. Most of them depend on public transportation or their own 2 feet to get them places. And so it was kind of a challenge to get them to come here for the training, but that's one component of the training. And then I had to go to them and work with them very intensely. If you notice on the training, it's a hybrid model. So there is 2 in-person training days and then online work. Again, if I'm working with people, almost all of our volunteers had little or no experience with computers, let alone any computer literacy or skills. So we had to go to them and bring the training to them for the online pieces, and then bring them back. In this process, they actually became Spokane Regional Health District volunteers. So now these are people who are volunteers for us, all of us in this room, and who are spreading the health messaging for us to their peers in their communities, which is extraordinary because, again, if you think back to that image, trust, huge, huge piece of the puzzle. And my life context is not like any of theirs. We're all very different, but I don't live in an apartment complex. I have no idea. I have shared that I've lived in apartments once right after high school and it didn't end well. So that's not my life context. So it didn't really work for me to go there to tell them what their challenges and barriers were or what they had strengths on site for. So going to them was the pivotal point. It shows that we cared. It shows they had a voice. And the more we listened, the more they asked for. And they didn't ask for incredible things. They asked for us to help them figure out how to work a transportation system. How can we access more fruits and vegetables? How do we do that? How can we grow our own food? There's a tremendous energy around community gardens among this population, but they don't have the knowledge and the skill set on how to actually make that happen. That's where public health comes in. We do. So it is just this incredible relationship between the community health advocates, their communities themselves, their apartment complexes, and what public health really brings to the table. Okay. Now, admittedly, I will try to calm my enthusiasm for this model because these folks are so near and dear to my heart. These are volunteers who are surprise leaders. A tremendous change happened during that period where I was working with them to get through the training. I said, well, can we all just come together? There's 4 property sites. I have 10 volunteers. Can we come together? We'd really rather you come to us. I honored that request. Took a bunch of time, a little bit of energy, and a whole lot of paper, but we made it happen. And week after week after week, I showed up to them. And suddenly, after about 6 months, they said, we'd like to all get together. Can we go back to the health district again, like you brought us around to become volunteers? Can we do that again? And I thought to myself, this is a model where somebody's small world just got a little bigger. They just realized that they could leave their space. They felt comfortable to leave their apartment complex. When I started, that was not the case. So now they become an advocate for go ahead and use the resources. Go out to a farmer's market. Go out. It's safe to do that. And the more they modeled it, the more their fellow residents noticed. Another huge change that happened with them as their world got bigger and wider is they started receiving the health messaging in so much a more meaningful way. One of my volunteers, I would say, was just surviving, sharing that they were just taking enough medication so they could just keep living. This individual now it's incredible. They have quit smoking. They have quit drinking. They're walking now 2 miles. Who would walk 2 miles just to get your blood pressure checked at a free machine? That's what they're doing, so they can monitor their hypertension and make sure that they're aware of what their body is doing. This individual is now walking around their property with hand weights and arm weights and riding their bike everywhere. And other residents are starting to say, "What's that thing you're doing? I notice you're a little bit more quick on your feet, a little more spry. What's that all about?" So now we have somebody whose life has been transformed and has only been on the program for a year, but their life is incredibly transformed, and they are being a silent role model. And others are noticing, and others are starting to think, well, if you can do it, maybe I can do it. And in my mind and my heart, that's a huge piece of some of their challenges is self-efficacy. I know that if I say I'm going to stop drinking coffee tomorrow, that'd be a rough morning, but for me personally. But I know that if I make that choice and I slip up, I can still go back and try again. And that's not the reality of our CHAs. So that's a huge difference to them, that their lives have gotten so much bigger. And I see my boss telling me we have to hurry. So at any rate, I could go on and on and on, but I just think that this model is so incredible, and it helps reach people that are typically in their apartments. I've heard over and over again that several people now are coming down saying, "What's next?" because they're coming to classes, and before, they never left their apartment. So this is definitely a model where we can reach people that public health and so many clinical services and resources in our community have never been able to reach. Sorry. Thank you for your time.
We get pretty passionate about this. So really what we would really like to see happen, first of all, is really recognition of the value of community health workers, in particular within community, like we were talking about. We talk a lot about root causes and prevention, and this is really where it happens. Where people live, where they interact, where they have opportunities to make the healthy choice or don't. And that's really the ground level of where we're working. And as we go forward, and there's a lot of conversation around potential reimbursement and payment models, and especially that clinical world, we in public health really feel committed to the fact that we need to continue to be that voice for the community piece of this. Another is that we really invite your input and your participation in this process. And as this model emerges, we would be happy to continue to talk to you or to come back and share more about this as we work to bring together folks and to find out what does it look like when we link them together and get some of the data on the outcomes of what happens. We welcome your input. These are the folks in your communities, and they really have the power to not only affect the health in their communities, but to provide feedback to you. And so we really appreciate you listening and hearing that, and would love to talk more or answer any questions you might have. My business card's in the back, and Marion brought hers too. So thank you very much.
Great. Well, thank you very much. Your enthusiasm shows very, very visibly, so thank you. Any questions you might have, either Marion or, Marion and Donna?
Well, thank you very much. This is right up my alley, so I ate everything up here. About 10 years ago, I helped develop a toxics education program with the Lands Council, and I didn't know that I think what I was doing at the time, I didn't really know it, but Ecology had given a grant and asked us to do education about toxics in fish in the Spokane River, and we needed to reach certain populations. And it was the folks that were the most connected and trusted in the community that were the most effective. Because you can hire someone that speaks Spanish, but if they're not connected in the Hispanic community and at the grocery stores and knowing people and people trusting that what they're telling them is true, then they're not going to be as effective. So I just think what you're doing is right on. And I was just wondering, with the Neighborhood Matters program, how does this model differ or support that model, or do you see the connections there? Do you guys work with them and how they're working with residents to identify what they want to change in their community, their neighborhood?
And I would invite Elaine to be a part of that answer too, if she'd like. We have worked with them in conversation on some things. I mean, there are some similarities in that we're in the neighborhood and working with and hearing from people in the community. I know that Neighborhoods Matter is focusing a little bit on some different topical areas and not necessarily, as far as I know, using community health workers, but some of the things that we've already done, for instance, as we think of implementing our nutrition curriculum and some of the classes and the cooking, Neighborhoods Matter has done some similar work there, and so we really tapped into what are the lessons learned, what should we be looking for and thinking about in working with folks there. One of the new areas, because we are expanding, we're going to double our locations this year. We're partnering with Spokane Housing Authority already, and we now have Kimley and Haygood on board. We have several properties that they would love for us to be in, and we right now are only slated to do about half of those. But one of those properties is in one of the neighborhoods that Neighborhood Matters has been in. So far, those are some of the things that we've done.
Yeah, I would just encourage that connection continues to grow, and as the city invests in different neighborhoods and has partnered with the health district, especially in the East Central neighborhood and now up in Hilliard and Whitman, if you can identify those housing complexes that are in those areas and leverage those resources, it would I think it would make a great difference. Because even though technically the Neighborhoods Matter work it's not pure community health worker, but the issues that come out of those conversations in community cafes a lot of times are related to health issues, and so just something to think about. But
I think that's a challenge we often have at the health district, is identifying those areas where we have some potential, not necessarily crossover, but collaborative points that we want to be really tapping into. So East Central is an area that we are newly going into, but we are also, one of these locations is in the Hilliard area. For instance, Neighborhood Matters was instrumental in the farmers market that they set up there. Access to the farmers market and partnering with them is a huge piece. And I want to, I guess, clarify, when Mike talked about Finney, that is a new grant opportunity also from USDA, which we were fortunate to be a part of, that is really going to enhance what we're doing here. It stands for Food Insecurity Nutrition Incentive. And what it will allow is people who get SNAP benefits to perhaps have an incentive that if they spend some of those benefits on fruits and vegetables, they get some additional dollars. So we have partnered with Department of Health. We're working with Safeway, the farmers market here. We will be actually implementing that program through our SNAP-Ed model with our community health advocates. And so there are perhaps more and more opportunities for us at the neighborhood level to be partnering.
Kevin?
I just have one quick question. And in deference to City of Spokane, I hear a lot about the neighborhoods in City of Spokane, but as the small cities rep, I'm wondering if you folks reach out to Medical Lake, Cheney, Deer Park,
Millwood,
Rockford. I'm more thinking about, from that standpoint, distant communities that they already have limited health access, a little more isolated. For this program, I realize you have to address your greatest population, your greatest need first, but what's the rollout for maybe looking at carrying this out into those sorts of communities?
Yeah, I mean, we've just started this SNAP-Ed program in Spokane County. Mind you, the community health worker training is regional. It's 9 counties. And so there is that intersection and that application. And we continue not just in SNAP-Ed, but in some other programs like our breast, cervical, colon health program, which is regional, to find to identify those natural helpers in those communities, help get them connected to this network, and therefore resources, which is a huge piece. Right now, I think our limitation is capacity, and we're just getting this program off the ground. It takes a bit to really build it right. You just don't go in and advertise and hire in 2 weeks and get the right people and really, get the trust built in that community. So I would love to see things expand. The partnership with Better Health Together, they're working at the regional level. So there are several areas within this topic that are beyond Spokane County. We do have one of our housing locations in Millwood area, correct?
Well, I can introduce you to the mayor. He can help you with that.
Okay.
Any other questions? Okay, thank you very, very much.
Thank you. And I would just like to extend my great heartfelt thank you to you for meeting some of the CHAs at one of the events in the Valley last summer. So we haven't forgotten that you've invited us to come to a council meeting. So when we have some results, we'll be excited to reach back out to you.
So I will give you 15 minutes at the council. No. Okay.
Thank you.
Anyway, thank you.
Thank you.
Any other questions at all? Okay, let's go to board member check-in, please. Doctor? Kevin?
I'm all talked out.
I am too. John? Amber?
I just wanted to thank the Health District for sharing Linda Graham to Linda participated, I don't know if she's still here, sat on, we put together a working group to give some recommendations to the City Council on earned, safe, and sick leave. And Linda sat on that group and did a great job. I just want to thank the Health District for lending her to that effort.
Okay. Yeah, Ed. Neat. Do I hear a motion to adjourn? Second?
Second.
All those in favor?
Aye.
Okay, thanks everyone.